Good afternoon. We'll call to order this June 15th meeting of the Tacoma-Pierce County Board of Health in study session. It is 3:05. Will the clerk please call the roll?
Chair Young.
Here.
Vice Chair Ushka.
Here.
Board Member Baggett.
Excused.
Board Member Campbell.
Here.
Board Member Danmeyer.
Excused.
Board Member Daniels.
Excused.
Board Member Morrell.
Excused.
Board Member Ryasich. Roll call is complete.
Thank you. I guess we do have a quorum, correct? 4 or 5. Because it's a study session, that's not necessary. I apologize, I forgot to turn on my microphone. I promise I'll get used to that. That brings us to section 3. We have a report from Denise Stinson, Communicable Disease Control Program Manager, and the title is Tuberculosis. Is that still a thing? And yes, it is.
Yes, it is.
Welcome.
Thank you, Chair Young and members of the board. Thank you for letting me talk today about tuberculosis. And it's a disease that we don't hear a huge amount about, but it's still very much a thing. Curing patients with active disease and preventing the disease takes a lot of public health effort and resources, and most of that work is behind the scenes. There's a lot of moving parts to TB care and prevention, and it involves so many important parts of public health work. Our work is basic disease control, but we also, it's very important to health equity work because TB is a disease where health disparities are almost always present in reality. So I'll just, let's see. The agenda today, I want to link our work to the strategic plan for the Communicable Disease Division and cover some basics about the disease, our partners, and program improvements made possible through foundational public health services funding. And one of our the communicable disease strategic initiatives is to control and prevent COVID-19 and other communicable diseases. And we're targeting tuberculosis as part of that initiative. So prior to 1800, TB killed 1 in 7 of all people who have ever lived on Earth, ever. So it was a very big deal and still is. 200 years ago, living conditions for most human beings on Earth were not healthy. Crowded living conditions, poor sanitation, poor quality food, and not enough of it. And these conditions are perfect for TB to thrive. So in the 19th and 20th centuries, when living conditions improved for much of the population, TB morbidity did decline, but it remained a leading cause of death in the United States and Europe until widespread use of antibiotic treatment in the 1950s. And the insignia on this poster, you can see the little insignia. That's the American Lung Association signature, but it used to be the American Tuberculosis signature because tuberculosis was the prevailing lung problem at the time. So tuberculosis is caused by a bacteria, but it's not just any bacteria. It's a very tough bacteria. You know, most illnesses that we have caused by bacteria, we can treat them in 7 to 10 days. TB, we need 4 very powerful drugs, usually for about 6 months. So it's very hard to kill. It is curable, but like I say, the treatment is kind of tough sometimes, and at least 6 months long. It does spread through the air. It's pretty contagious, but it's not as contagious as, say, COVID-19 or influenza. You really have to have several hours of exposure, usually, to a person with TB to be infected. It can affect any system in the body. The lung is the most common. It goes in through the lung. And people can develop drug resistance if they don't take their medicines every day and correctly. And so that's why, we really are very, very involved with TB care as a public health department. So who's at risk? And here's where our disparities are so evident. Most people who are at risk for TB were born in areas of the world where TB is really common, or perhaps they were recently exposed to TB, they've had close contact with a confirmed case, or they have medical conditions that weaken the immune system. Our most frequent condition that is a precursor to TB, breaking down into active disease, is diabetes. So, that is very common. So, the two of them together. Also, people that are living homeless are at increased risk, or people that are using drugs or who are using alcohol, have alcoholism, or who are incarcerated. So this graph depicts the the rate per 100,000 cases per 100,000 of population. And it's kind of hard to see. Pierce County is the orange line going up and down here due to the variation from year to year. In Pierce County, we have about 15 to 25 cases per year. And that's a rate of about 2. And it's kind of the same for the state. We are all hovering at about 2 cases per 100,000 population. Pierce County is a little lower than the United States or Washington State. So just keep that figure of a case rate of 2 in your mind.
Does that include latent cases, or is that just active disease?
Just active disease, right. Just active disease. So the areas of the world where TB is really very common, you can see the dark colors here. And so look at oops, I got my pointer and my move ahead are mixed up. The really heavy areas, heavy burden areas are sub-Saharan Africa, and then areas of Asia, India, and the highest rate here is over 300. So whereas in the United States we're 2 to 3, they're 300 or greater. Well, I'll just go over, there's a difference, and Chair Young mentioned about latent disease, so maybe I don't really have to say a lot about it, but actually that confuses a lot of people. Latent infection is where you breathe the bacteria in, you've had exposure, you have the TB infection. The TB, we explain it to patients, the TB germ is sleeping in your body, and it might wake up later. In only 5 to 10% of cases is it going to wake up. Most people's immune system is going to keep it at bay, maybe their whole life. The problem is, if you look at the map, 25% of the world population has TB infection. That means they've been exposed, that germ is in their body, okay? Now, it's not 25% of the United States, but overall, 25% of the world population has TB infection. So, of course, not 25% of the world's population is going to develop TB. But think about 25% is a stunning number, and 5 to 10% of those people will. And so, the more people that we can treat for infection, and it's much easier to treat for infection, the better. And, here in the United States, here in Pierce County, and worldwide, of course. Another thing, too, people with latent infection, it's sleeping in your body, you're not sick with it, and you're not contagious. Once you have active TB, you could be contagious. Many of our patients are. Not all of them, but many of them are. And so if we can get those folks before they develop active disease, treat them, we help them for later in their life, and we also help their family and the community, too. This is a tip of the iceberg thing from the CDC, so it kind of shows you, these are our active cases, the tip, the people that we know about, and those people are sick. The underneath the water is the millions upon millions, really, of persons with latent infection. Most of them won't be sick, but a certain percentage of them do, and the number is just huge. One thing that I did forget to say is that, worldwide TB is such a problem, and I thought you'd be interested in that TB is actually the second most prevalent communicable disease killer after COVID-19. So before COVID-19, just 3 years ago, it was number one. It was number one. It's been number one for many, many years. HIV was number one for a while, but TB is now number two after COVID. So just to talk about our program, a lot of our patients need a lot of help. We don't have huge numbers of patients. If you think about it, 15 to 25 patients doesn't sound like a lot, but they need a lot of intensive help from our staff. In many cases, many of them are non-English speaking. They may be uninsured, or they could have problems meeting their basic needs. They could be drug and alcohol affected, different things like that. So our TB nurse case manager and our outreach workers work together to support the patient through this long treatment that sometimes can be difficult for patients. And what's really more difficult for patients is being isolated, because they have to be isolated when they're contagious. We can usually get them out of isolation in a matter of weeks, but when your income, you can't go out and earn a living, or you have to be separated from family and friends. It's very difficult for patients. So anyway, our staff works very hard to support our patients through this. Our outreach worker does what we call directly observed therapy, and what that means is that our outreach worker watches the patient every day to take the patient's medication, 5 days a week actually. We give them a break on weekends, but they take their TB medicine Monday through Friday every day, and they're watched by a health worker. We are able, once the patient's stabilized, we're able to put them on a video system if they, are if they want to do that. And a lot of the patients really love this, because they can take their medicine at any time. They don't have to wait on the worker to come and watch them. We give them a small supply of their medicine, and then they can take it when they want, but they have to video themselves, and then they send the video to us later. And Pierce County, I'm so proud to remember that we were one of the first health departments in the country that was doing that kind of observation through a video. And we didn't have a phone app. We had an old-fashioned machine that it was kind of like, there was a TV show where, I can't remember, Star Trek or something, and a person had a phone and a screen, and it was like that, and it was terrible. We really couldn't see very well, and we only put patients on it that we really trusted that they were good to take their medicine. But now we have the very clear pictures of the cell phones, and the patients really like it and appreciate it. In addition to taking care of our patients with active disease,
one second. Apparently, we have people on Zoom and they're having trouble hearing.
Oh.
Can't hear at all, or.
Can't do anything about the audio unless you're okay.
Do I need to speak louder? Or?
Yeah, just make sure you're speaking directly into the mic. And
Thank you.
Okay. In addition to taking care of the patients with active disease, we test and evaluate the close contacts of the person with active disease. And those are usually the people that live in the same house, but occasionally we do have to go to a workplace or a school or somewhere. We've actually done testing at homeless shelters because a person has stayed in the shelter, and we've also gone to schools. In addition to staff activities, we also have our health officer responsibilities in terms of sometimes we'll get a patient who for one or another reason isn't cooperating with our plan of care. And so our health officer, Dr. Chen, does have the ability to order testing and treatment and isolation if necessary. These are our partners that we work with. Our staff, we have a nurse and our outreach workers, and then we work with physicians, Franciscan infectious disease physicians. They do our TB care. Dr. Lawrence Schwartz is retiring. Dr. Reisich, he'll retire on June 30th. He's been our TB doctor for 25 years, and we'll miss him so much, but we have Dr. Elizabeth Moon will be our doctor going forward. But we also work with Community Health Care and CEMA to do treatment for latent TB. We have contracts with them, and we will pay for uninsured persons to get care for all of these conditions through a health department contract. And I forgot to list on here our very important pharmacy partner, Kirk's Pharmacy, who provides very beautiful unit doses for all of our patients. They take a lot of medications, and we provide the patients with a packet each day with all those medicines already put in there by Kirk's Pharmacy. Community medical providers can test and treat for latent disease. A lot of them don't do this. There are a lot of competing priorities in the medical setting, and for diseases that aren't making the patient sick that minute, sometimes it's a heavy lift to remember these screenings that are important for people to have. So part of our program going forward is we're really going to try to start working with community medical providers more to test and treat for latent infection. So our goal, I did mention our goal as part of the strategic plan earlier, but our goal going forward is, our overarching goal is that people in Pierce County who have TB infection won't develop TB disease, and our strategies are to increase the proportion of contacts to cases tested, evaluated, and treated. We want to train community medical providers on new regimens for TB infection, and we want to provide case management and support for patients to complete the medical regimen for TB infection, which is different. Because we didn't have the bandwidth before to actually case manage people with infection, but high-risk people, like contacts to active cases, children, perhaps people that are high-risk from medically high-risk, or perhaps people living homeless, people that a doctor could report to us, this person really needs support and really needs to take the medicine. We are going to try to do DOT for those people also, directly and appropriately, which is different. We've only had bandwidth to do that with our active cases. Now, because of foundational public health services, we have one more outreach worker, and I'm adding a nurse, and it's just so exciting because we've never been able to do this. So, I think that's all.
Great. Well, thank you for the presentation.
Thank you.
Are there questions from the board? Yep. Yeah.
Like that. Okay. So thanks, Denise. That's really interesting. I'm curious. I'm a little bit surprised to hear that Pierce County is lower than the state average in terms of TB cases. And is that something that we can be proud of at the Department of Health? I mean, is that because of our intervention?
Well, I'm proud of it.
Well, considering socioeconomics of Pierce County, I would think that we would be at the other end of the scale. So where are the hotspots in? The
hotspots are King County, and I think it has to do with immigration patterns. King County has kind of been, King County receives the majority of new immigrants for the state, and so they really do have the lion's share of TB cases. And we do also. Not all of our patients are immigrants, but many of them are. And so I would say that that's the reason why we're only a little bit lower. I don't know that it's really all that significant, but I'm very proud of our. I'm very thankful for what we're going to be able to do, and really appreciate the board's support for the increased funding that we've received.
Too, which is, what's the mortality rate for tuberculosis these days?
Gosh, here in the States it's probably not high, but I'm not really sure. Although during COVID, the early months of COVID, we had 2 deaths. Yes, and one of them was reported to us by the medical examiner, never been diagnosed. The other one was a fairly young person, but presented to the emergency room, and the person had symptoms for a long time, and I think because of COVID, and also there was some hesitancy in medical care, just like fear of medical care and trying to self-treat and things like that. But we had 2 deaths, which was, we were very worried about that for a while. And COVID did prevent a lot of diagnoses. I really think King County did a study that was reported in the MMWR within the last year about delays in diagnosis and such that we attribute to people just not being able to get diagnosed because of COVID.
I do think it's fair to say that, given the risk factors that we saw, for active TB, it's clear that Pierce County could potentially expect to be at higher rates, and so I'm going to say that I think that our departments had done a great job trying to keep that down. And it's also important, given the fact that if you recall, when we do our budgeting, the cost associated with TB cases is extraordinary. We have lots of financial incentive for the public to avoid those kinds of really expensive interventions. So,
one thing I failed to mention, and Karen just reminded me, the really expensive cases are the drug-resistant cases, and we did have a couple of them a few years back that we had to ask for extra funding from the city or county or both. The medication regimen was $100,000 or more. So that's why we really very carefully manage our patients, because if they are spotty on their medication adherence, the disease, if you don't hit it with all guns, it can rise. It can I don't want to say mutate, but it can develop resistance. And here we have a real problem, and that happens.
Board Member Campbell.
Thank you, and thank you for the presentation. The post-conversation got me thinking in a couple different directions. So one of the risk factors you say, and primarily we see it among immigrants here locally, and then incarceration. So is the Northwest Detention Center a large location for us to identify cases?
Actually, we do not manage cases that are reported from the facility. The State of Washington Department of Health manages those cases, and they do have a few, at least a few a year. They do.
But do those count against Pierce County
No,
statistics?
they do not. No, they used to. We used to count them in our count. We stopped doing that probably about 2015. Nigel, can you remember? It was about 2015 that the state took on all the management of those, and our doctor at the time, Dr. Hero, convinced the state, really, these folks are coming from all over the country, to the facility. They may or may not have being ever in Pierce County before. So I think that was a good thing because it made our numbers look kind of artificially high.
So where are those being counted as?
The state. The state counts corrections, all the corrections cases, and that's part of it. Mm-hmm.
Then also with this being having our immigrant communities, do you work with the City of Tacoma's Commission on Immigration on getting the word out through any of those?
Yes, Sue Moon, who is our refugee and immigrant health coordinator, works with them, and I think they asked her to apply to sit on that. It could be the state, but yes, and we work with Tacoma Community House and other, certainly the resettlement agencies. And also, as we have more staff, we're adding more, we'll have more ideas. Working with the community engagement groups that have been put together from COVID, I think we're going to work together with them. They've done so much work, and that's only going to help us as a department going forward with all kinds of work, including tuberculosis.
Vice Chair Huska.
Thank you. Just a quick comment for my colleague. And I can't talk about the Northwest Detention Center here and not give a minute to thank the Health Department for their partnership with myself and Councilmember Walker, working with advocates to really making sure that we are doing what we can as a health department here, even though it does come under state health guidelines and then the National Health Service within the facility. So I just wanted to give that shout out. Thank you.
Okay, not seeing any more questions. Thank you very much for your presentation. That brings us to section 4. What did COVID-19 teach us about data? And presenting will be Naomi Wilson, our community assessment manager.
All right. Oh, nope. That's not the right one. All right.
And while we're doing that, this will be our last meeting with these microphones, so
right,
bear with us.
Try to lean in as much as I can. All right. Right. Good afternoon, Chair and Board of Health. Thank you so much for this opportunity to speak to you today. So, the agenda for this presentation today, we'll be exploring how we use data, what it can tell us, and what's on the and what's on the horizon. I'll be updating you on some new partnerships that we hope to provide, we hope will provide us more current data and new data sets that will allow us to answer more questions. It's important to note that when I talk about data for this presentation, I'm referring to both quantitative and qualitative data. So it is not just the numeric data that we collect or that we present, but also the data that we collect through focus groups and through interviews. So I'm starting this presentation with a question to the board, which is, we've heard from you numerous times that you've relied on our COVID-19 data. And my question to the board is, what did you find most helpful and how did you use it?
Anybody want to take a first crack at that? That sure is good.
It seems like 100 years ago that we were sitting at the beginning of 2020 or this time in 2020 trying to figure out the data. And I don't know that, I kind of looked at all of it, right? But it was from case counts and then disparity information and how we were reaching out to folks were really primarily how I was looking at what the city could do to help augment that work at the time. But I know that, across the county, that daily case rate kind of predicted everybody's lives. So, how's that for a first stab, Chair?
Outstanding.
Thanks, Mr. Chair. So for me, that I agree with. That was the one that I looked at every few days. The state hospitalization rate, of course, being in the hospital end of this, the biggest fear is that we were going to get overwhelmed. So knowing what the hospitalization rate was like, and then the mortality, both the number of deaths, but also what the mortality rate was. Because remember, there was that debate back 2 years ago whether it was 3% or 5% or whatever, and those numbers were pretty critical to how we fight it. And I guess the happy news is that number, the mortality rate now, is really low compared to the number of cases. So those are the things I looked at.
Board Member Campbell?
Thank you, Chair. Well, I looked at every piece of data I could find, and from hospital rates, I looked at local, state, national, international rates, how we were doing compared to other states, how we were doing compared to other counties, and yeah, just check that data on a daily basis. And a lot of times I used it. There were, might surprise some of you, there were skeptics of the pandemic out there, and being able to go to the data and actually show it didn't always convince them, but at least I knew I was doing my part to try to get the factual information out there as often as I could, so that people could make their best decisions based on that. And so being able to use it to support arguments was helpful too.
Yeah. And I think that's, for all of us that are elected officials in particular, helping build trust with the constituents. Didn't always work, but for a lot of folks, we became an essential source of that information so people could make their own risk assessment.
Yeah. Well, I certainly thank you for all of that input. And one of the goals for me as community assessment manager is to translate that interest in our COVID-19 data into other health indicators as we move forward in the months and years to come. Providing data on the health of our community, as you know, is a core function of public health. Data can be used for disease surveillance, such as COVID-19. It can be also used to evaluate program impact, to monitor progress, determine populations to target for an intervention, and identify gaps in access to care. The number of questions that we can ask is endless. However, we cannot answer every question. So we prioritize answering questions that have meaningful public health response that will improve the health of our community. To be useful, data should be of good quality. The higher the quality of data, the more likely that there is trust in the conclusions that we draw from that data. We frequently are looking at these four elements to make sure that it's accurate, complete, relevant, and timely. Even though our data is not 100% accurate or complete, it can still be useful. For example, we are launching our wastewater COVID-19 surveillance. It is up on the CDC's website currently right now. Now, that will represent one piece of data from the Puyallup wastewater treatment site. But we can look at that to see if there are trends in that data. And we look forward to bringing you that information in the weeks to come. So these are some of the core data sets and systems that we utilize. You heard my colleague Denise Stinton talk about tuberculosis, which comes from our Washington disease reporting systems. We use a lot of our hospital data systems to do reporting. When Division Director Chambers brought you the opioid cluster and reported out on that in Pierce County, a lot of that data came from our electronic surveillance system, so our hospital data as people show up in the hospital. We also utilize a lot of our vital records here at the health department. So along with that, we also use self-reported data. These are on 2-year cycles for our health and youth survey, as well as our behavioral risk factors. You'll be hearing a lot about the BOFIS data. We'll bring our county health rankings presentation later this summer or early fall. You may or may not know, but also...
That's what we're calling it? BOFIS?
BOFIS, yes. Our health and youth survey data skipped a year during the pandemic. So we did not get the 2020 cycle, but we do have the 2021 cycle. We monitor that very closely as part of our Healthy Resilient Children and Youth Initiative. And then the SMILE survey, which will be administered this year, the first time since 2016. Here at the Health Department, we center community voice in our data. We know that making significant systems and environmental changes requires sharing power with community members. There are social, cultural, economic, and political factors that influence health and disease. Some examples that you've seen of this are Pierce County breastfeeding community conversations from our Black Infant Health Program, as well as most recently our COVID-19 listening sessions, where we really listened to the community and how they are being disproportionately impacted. I'm also excited to let you know that we have a new core data health set to add to the ones that we already have access to. This is Washington all-payer claims data. So Washington all-payer claims data contains commercial, Medicaid, and Medicare, dental, and pharmacy claims for about 70% of Washington state residents with insurance coverage. Some of the new and exciting questions that we're hoping to answer with this data set are zip code level disparities in diabetes diagnosis in the region. When epidemiologist David Feiberg brought you her mammography report, she's interested in exploring what types of women get mammograms and how does that compare to the overall population. For potentially preventable hospitalizations, we hope to use it to understand who is charging for tobacco cessation. The all-payer claims database is a very complex and large data set. We are partnering with Seattle-King County and Spokane Regional Health District to explore using this as a tri-jurisdictional data set. And we're using foundational public health dollars to provide some of the support for this. We've also developed some really exciting new partnerships. I'm going to pause right now to introduce to you, if you have not met, our medical examiner who came in during the pandemic, Dr. Klein. You want to step up? You want to step up and introduce yourself? Dr. Klein has been really just a phenomenal partner for us at the health department. She's allowed us to send 5 of our epidemiologists over to shadow her in her work and the work that her team does. And I'll just give you a minute to introduce yourself. Dr. Klein.
Good afternoon. Thank you. It's an honor to meet in front of the board.
If you could step forward a little bit, you need to literally swallow the microphone.
Okay. Thank you. So hello. My name's Dr. Karen Klein. I'm a forensic pathologist. For those who don't know me, I came here in May of 2020. I have a specific interest and previous experience in public health as it relates to medical examiners, infectious disease surveillance, and some of the interesting kind of more high-profile things that relate to public health that I've been involved with that I think is really exciting is I was trained in New Mexico by the forensic pathologists who recognized hantavirus pulmonary syndrome in 1993. They recognized the syndrome due to index cases of two folks who passed away, and they engaged the CDC, Indian Health Services, all of this collaborative effort that then went into actually identifying the causative agent of that disease. So that's my roots of where I come from and why I'm passionate about the medical examiner's office being, we're not there for the deceased, we serve the living. That's our mission, we serve the living. And in our partnership with Tacoma-Pierce County Health Department, part of that is with providing data. We just got a new case management system that we're still learning how to use, and because before that we couldn't really extract any data. So now we're learning, and I thank you very much for the opportunity for this collaboration.
Sure. Can I just make a quick comment? Please. Hi, good to meet you. Hired you 2 years ago online and have not had a chance to see you in person. So
Yes.
I hope that you're getting the support that you need here in Pierce County, and that I really appreciate what you've been doing in the office. We've seen, at least through budget requests, the work that you're doing, and it looks very good. So thank you.
Thank you very much.
Thank you, Dr. Klein.
Yeah, Anthony Chen, Director of Health Department, Pierce County Health Department. Just want to add, Dr. Klein's just been fabulous. I remember early in the pandemic, there was a lot of concern about are more people dying at home because they're afraid to go to the hospital. Her office gave us data on what they were able to see. I know she was wanted to make sure that they were able to test for COVID postmortem, so they're another surveillance site for us. And she's also just been very proactive in talking about injury prevention, reporting into databases. Chair Young, you're very interested in the opioid dashboard, right? So they've been very helpful with us getting data on that as well. So just want to add my thanks to Dr. Klein.
Thank you.
Yeah, and Dr. Chen stole a little bit of my thunder, so yeah. We are working very closely with the medical examiner's office to get a not just an opioid dashboard set up, but a non-fatal and fatal drug poisonings dashboards, and part of that means getting quarterly data. So Chair Young, I know that that was a specific ask from you and for the board, is that we be able to provide more timely data, and partnerships with the medical examiner's office really allows us to be able to do that. As you may or may not know, some of our death data that comes from the state can take up to 2 years to get all the way down to us here at the health department. So having that kind of timely data really helps us. Also, board member Ashta, I know that you have asked specifically for us to look at what the public health lane is for our homelessness response here in Pierce County. And I just sent over a request to Pierce County Human Services yesterday to explore the partnership and having access to our homeless management information system. So part of that will really help us not just to understand the root causes of homelessness, but it will help us to look at outbreaks, to respond to those for shelters, to identify our COVID rate within shelters, and to lean into the comprehensive plan that really identifies data systems across multiple sectors to be able to address complex issues. We'd also like to thank the Tacoma Police Department for providing us data. Our Centers for Excellence has contracted with the City of Tacoma to do a youth and young adult violence assessment. This is new data for us, and it's an exciting partnership that we're looking forward to presenting to the city as the Centers for Excellence later this summer. And then also on our community engagement, you also heard Denise Stinton talk about tuberculosis and our community engagement. They're a key part of everything that we do. And one of those activities is also a Native Hawaiian Other Pacific Islander task force between King County and Pierce County, and particularly focused on the TB outbreak within the Marshallese community. Would like to make sure that I acknowledge within these new partnerships, there are still existing partnerships. So our healthcare systems and our medical providers just continue to support us in the partnership in and out of the pandemic. They've always been here, and we appreciate their support. All right. So where are we now? Well, the field of public health is highly interdisciplinary and includes a wide range of data sources that's always evolving in size and complexity. This is the structure that allowed us to meet the data needs of our COVID-19 response here in Pierce County. So I want to thank the board for their support for public health systems and the funding that supports it. I also want to thank you for your support for developing these cross-sector partnerships. They're really the key to moving forward to addressing complex and ever-evolving issues in Pierce County.
Thank you very much.
Thank you.
Any questions? Well, thank you again. I'm really excited about the direction of this, and there's, as Dr. Chen mentioned, particularly on the opioid side, I think we owe it to the public, particularly as we see the national trends and trends in kind of peer communities, seeing those poisoning rates and mortality rates increase. We need more live, or live-ish kind of data to be able to tell the public this is what's happening in our community, and we need to address it, because I think that's one of the things that where public health really can rise to the occasion, and I look forward to seeing more.
Thank you.
That brings us to section 5. Oh, I apologize. Remember Risich.
Thank you, Mr. Chair. Who witnessed the data that we're trying to collect? I mean, there's some holes in it, right? So you talked about 30% of people are not under the all claims database thing, but in our county there's also a large tribal presence, and do our information about tuberculosis and these kinds of things cover that, or is that a separate organization that worries about public health on the reservation?
Yeah, that is a very timely question, and just attended briefly a presentation on Monday. There's a presentation, I think, another presentation happening in about 8 minutes. Department of Health is working on a data sharing agreement with the tribes, and part of that will be to acknowledge the sovereignty of tribes and the data that we report out. So that's something that is evolving kind of right now. But I'd be happy to update you further when we have more information. Or Dr. Chen, if you'd like to.
Well, at the very least, I'm pleased to hear that we're going to be working with those folks.
So, Dr. Risich, you're absolutely correct. Healthcare data is more like Swiss cheese, right? So, we have some really good public health data sets. But if you think about something like asthma, we don't actually know how many kids have asthma in Pierce County. And we know how many died from asthma, we know how many got hospitalized for asthma, we know how many, with our payers claims database, we can see how many people saw their doctors and were billed, right? Our payers claims database is a payment system. However, if a parent takes a child to see their doctor, and the doctor says, I think your child has asthma, but then, some doctors don't like to code asthma right away because there's implications for, pre-ACA, implications about whether you could get covered with insurance. That never gets captured, right? So, there's this, you work in Epic, about your electronic health records, so it does all kinds of things, but we never see that data. And so like depression, right? So in Epic, the primary care providers are prompted to ask their do a PHQ-9, a screening test. We don't see that. So we get it, and we will in the future through our payers claims database. We will see it if on Healthy Youth Survey the child reports that they suffer with depression symptoms, and both those for adults if they report that, right? So you're absolutely right. We wish we could get better data, but this all-payers claims database is the next quantum step. It's literally a quantum step because it's not a survey which does a sample of the population. It's actually the physician interactions. But as you saw with when Sabrina did the presentation with other things, right? So the potential cluster overdoses came from the emergency room surveillance system. But yeah, we're always looking for more ways to get data.
Thank you. As I sat here, I realized I had questions from the beginning of the presentation. You were talking about the county health rankings and the fact that we didn't get to do the Healthy Youth Survey in 2020.
Yes.
This board tends to have a lot of conversation about where we rank on the county health rankings. Is the absence of data from 2020 going to affect our rankings one way or another? And is there a way to adjust for that in the rankings?
Actually, it is our breakfast data, so our behavioral, can you remember that?
I remember the acronym.
The acronym, right? That's used in our county health rankings, not our Healthy Youth Survey. And when we bring the county health rankings to the board later this summer, early in the fall, that will be data from 2019. So when I'm talking about timely data, it still won't be reflective of the impacts in the pandemic, especially around death data and leading causes.
So if I were to ask you what's the number of youth reporting depression now compared to 2019, you couldn't tell me?
No, that we could tell you with our Healthy Youth Survey.
Okay.
Yeah.
Okay, thank you.
Yeah.
Thank you again. And that brings us to Section 5, our COVID-19 update. We will be getting that presentation from Nigel Turner. By the end of this, I'm going to be able to say that on the right the first time. Communicable Disease Director, or Control Division Director. Thank you, Mr. Turner.
Nigel Turner is Division Director of Communicable Disease Control. Chair Young, members of the board.
To get it right.
Yes, I've been practicing for a while, and it takes a while to get there. Let's see. So, providing an update on our COVID data. I'll be talking a little bit about some advertising that's going to be coming up, some of the messages we want to be highlighting in the next while. Talk about update on our treatment promotion program, and then highlighting a very valued program partner in the community, and then of course finishing off with any questions. The COVID data, as you know, as you heard from Naomi's presentation, we emphasize and prioritize the data that we collect, and there's a link in the PowerPoint that will take you to the latest data that's updated many times a week. In terms of the trajectory of the pandemic, we've been having increases rate of COVID over the last couple of months. It's been a slow and steady increase. The majority of this still caused by the Omicron variant. And the good news is that recent data suggests that's plateauing, which is good. We did see actually a slight drop in the case numbers from 263 per 100,000 for 7 days to 231 for the most latest data. We also saw a slight drop in the positivity rate for tests, which still remains high, but it's a welcome drop. Likewise, outbreaks, still very high levels. We saw 804 cases associated with 96 outbreaks. So our outbreak investigation team working every day has their work cut out, but that is a 10% drop from previous weeks. Now, to temper this, the hospitalization data has actually shown a slight increase. The hospitals remain very busy, not just with COVID, but also with issues caused by staff shortages and vacations and burnout of staff, and it's the backlog of treating patients due to delays during COVID. So they're certainly under pressure. But our hospitalization rate increased to 10.7 per 100,000 for 7 days, which does actually put it up into the CDC high level for community transmission, although there's no certainty of that. There's a site, they use different data systems, so we'll be ready to communicate that out if it goes in that direction. But the point is that COVID is very much still here, and very much something that we are working on and continuing to control in the community. And our emphasis, as always, is going to be around the various things people can do, but always the focus is going to be on vaccination. And the big news there is that the long-awaited expansion of age down from 6 months to 5 years is upon us. We expect full approval this week. We've been monitoring it very carefully, working with our community partners to make sure they're ready. We expect full approval this week. We've ordered vaccine to arrive on the 21st. It'll be available through our depot to community providers throughout the community so they can get small numbers. And we have 32 providers, actually more than 32 providers, who are ready to give the pediatric vaccine to the public, in addition to our public sites which are listed on our website. So we really want to be pushing this out in the next while, and part of that's going to be a re-emphasizing our advertising. I think we shared with the board, we have a new strategy in place for media buying, which gives us better value for money and broader outreach. And there'll be new digital billboards and I-5s, Spotify videos, TV spots in multiple languages. Again, initially emphasizing the vaccine and the new information, but then later on broadening the message into other things such as testing and other prevention messages. Seconds. Catch up with my notes here.
In this, I guess maybe not in the advertising itself, but in some sort of communications, are we going to try to, help re-educate the public on risks to children? A concern that I have is that we've obviously seen a lot more hesitance for parents of kids, and I think part of it is, early on there was misunderstanding about what the risks were. It appeared that children weren't getting sick from it, which is still the case, but we are seeing significant numbers of long-term type risks that I think parents should be made aware of. Are we planning anything like that?
Absolutely, yes. We continue to look at and to share the data about the very significant risks from COVID, and long COVID is certainly part of that. We're still learning about this virus, and it's certainly something that we want to highlight, and that'll be part of our communications going forward.
Good. It just feels like, I compare it, a lot to polio, for example. The virus that causes polio is very, very rarely causes much significant illness, but when it does, it causes severe harm to kids, and so that's why we work so hard to eradicate it. But I just worry that there's so many parents out there that are like, well, the vaccine seems like a bigger risk to me, and so they're going to be more hesitant. So anyway.
Yep, absolutely. So it's making clear that there's that risk-benefit, and certainly in terms of COVID, the benefits of the vaccine certainly far outweigh any risks for what is a very serious disease for us all.
Thank you.
So moving on. Test to treat program. So as I say, we have multiple layers of protection from COVID. We talk about testing, vaccination, isolation, quarantine, infection control, but I think an important part as well now is treatment. And we've been sharing with the board our work to promote treatment, and we've been working with our community providers to make them aware of this and to make sure they have access to antivirals through the state. We currently have 105 providers in Pierce County distributing antivirals. We were looking at kind of reducing the barriers to treatment, and one way you can do this is making it as simple as possible between somebody testing, between getting assessed, getting a prescription, actually picking up the meds, getting as simple as possible, kind of that soup to nuts approach, and really encouraging putting those services together. So we partnered with the State Department of Health to offer a test to treat program funded by state dollars, partnering with Birdseye. This allowed us to combine somebody testing positive at one of our public sites to be able to access assessment via telehealth with a medical provider then and there, and then get a script that they could then take to a provider that we could, to a pharmacy that we could identify. They could get the meds and start treatment as soon as possible. And this has worked out well for us. And yes, to date, we're averaging 40 of those telehealth visits, following up on this with visits, 156 visits total. And looking at this data from the studies that are out there, which look at the preventive effect of treatment, we predict that we've been able to prevent at least 9 hospitalizations and 1 death just from this work alone. And this model's been successful in Pierce County, and the state is looking to expand this beyond into other areas as a way of improving care. Now, a challenge here is that we haven't seen great equity in the people that we've seen through this, and that's our challenge. That's why we need to get this word out, improve what we're doing, and increase access to it. Okay. Now, in terms of the test to treat, the pharmacists have been a key partner in this, getting the medication out. But test to treat is just one part of this. Pharmacists have been really allies for so much of what we've done in public health, both during COVID and before. During COVID, they've really been able to step up when healthcare providers have been maxed out treating patients. They've offered really massive amounts of testing in our community and really been a valuable adjunct to public health and healthcare generally to meet the needs of the community. But it goes beyond just even COVID. In fact, they're key allies in childhood vaccinations overall. And we'd like to highlight today the work of one of these heroes, which is Kirk Hines with Kirk's Pharmacy. He's actually been one of our allies for a long time. We have a Vaccine for Children program, which distributes vaccines free to the community using state and federal funding. Kirk's Pharmacy was only the second pharmacy in Washington state to sign up for the Vaccine for Children program, but since then has been a key partner in providing vaccinations through his pharmacies in Pierce County, particularly in the Eatonville area. But then stepping up through COVID, and you actually just heard about his help with our TB program, but through COVID, he's offered testing in numerous times, as well as offering vaccines, and to date, over 33,000 doses have been given by his pharmacies. So just a tremendous ally, and very happy to call him a partner in our work. And I'd like to invite him up just to say a few words, if possible. He's here with his son, Andrew.
He's going to get a thing from Dr. Chen.
President of the board and the members of the board, it gives us great honor, both my son and I, to be able to be invited here to tell you a little bit about what we've been able to do for our community and for Pierce County. Like Nigel had commented, we started off partnering with the health department for flu vaccines, worked with the Washington State Pharmacy Association and helped to get vaccine for children. And then we were lucky enough to be one of the pharmacies that received the COVID vaccine. Moderna to start with, and we were getting calls from all over the state, people wanting to come in. And so within the first week, I had set up a mass vaccine clinic coordinated with our Eatonville School District to utilize the auditoriums. And we had cars backed up out of Eatonville for 5 miles waiting for the vaccine. We learned a lot from that event, and to this day you've seen how many doses we've been able to give. We've gone out south as far as Ashford to folks that would not get a vaccine if we did not go there. The health department invited us to go to Carbonado, as far east as we could, and the school district that we worked with there said a lot of residents here would have not gotten the vaccine if you wouldn't have come out. And my son was able to coordinate with the fire and police and went out when we were given access to Johnson & Johnson vaccine, and he went out and vaccinated homeless to be able to help get as many people in the county vaccinated as we could. And today we're still vaccinating, and I'm still trying to do our part to make Pierce County shine. So my son's going to talk a little bit about our test and treat program.
Chair and members of the board, thank you for inviting us today to speak. It's a great honor to partner with the health department over the years. We're the pharmacy that comes and vaccinates all the employees of the health department every year for their flu shot. I do all of their tuberculosis screenings. I've worked a lot with Denise on the tuberculosis treatment program for the last few years, so it was just kind of a fun highlight of all the partnerships that we enjoy working with everybody here at the health department. Cheryl's been a great resource with vaccines and kind of just helping us move along as we learn more about this virus and through the pandemic. From vaccines to getting testing. We're working with the Washington State Pharmacy Association on a grant to be able to provide all of the free tests for all of those exposed, increasing, our public health capacity. And then she called me a couple months ago about the Test to Treat program, and we said, yeah, let's do it. It was a very seamless thing. We were already doing the testing. They had amazing, flyers and communication that we could, give out to our patients. And so once we got the antivirals in, it was really easy. Having the bird's eye resource is very convenient for folks, because on that handout we just say, call this number after we report to you that you tested positive, or we get actually a lot of calls of like, hey, I tested positive, now what do? I saw you on the website, and they're like, okay, here's the number. They'll send us the prescription, and then call us when you get here, and we'll bring it out to you. It's worked very, very well. So we appreciate everything that you guys are doing to help support us, support our community, stay healthy. Thank you.
How many have we done to this point?
Testing-wise, we've done almost 4,000 tests over the last 6 months, and we've dispensed almost 80 Paxlovid prescriptions in the last month since we've had Paxlovid. So it's working very well. Thank you. Any questions, I guess, for us?
Any questions? Okay. Well, and I think we have something for you as well to show the department's appreciation. Dr. Chen?
Oh, wow. Thank you so much.
Sure. Let's get a picture here.
Yes.
Both of you.
Let me choose the mode. I'm recording. Embarrassing, embarrassing.
Wow.
Alright.
All smiling, right?
All right, that should be enough. Thank you.
Great. And that concludes the COVID update. I'd be happy to answer any questions.
Thank you. And I did just want to say thanks again to Kirk's Pharmacy. The industry has definitely consolidated over the years, so having local folks that are able to partner with us is great. And the thing I'm really excited about is to hear how that Test to Treat program is going, because that feels like how we, continue to protect people who are most vulnerable while also restoring some normalcy. So the more we can scale that up, the better. Okay.
Thank you.
Thank you. Oh, we do have a question. Board Member Rice.
Yes, thank you, Mr. Chair. With the onset we got like 6 of these home test kits at home that the post office sends you, right? And so a fair number, maybe even a majority of tests now are not being done in a place where they automatically get recorded. Well, I know that you don't know the answer to this question, but what do you think the impact, how many cases are we missing, and how skewed is our data because of the home testing?
Yeah, there's actually some assessment work that's done on that, which looks at kind of what's our anticipated volume percentage. I think we're about 30% probably of the actual cases are being reported because, as you say, people are testing at home, but it's only kind of a calculation and based on modeling. And that's why really we need to kind of think differently. We won't get all the cases reported, and that's okay. I mean, we really need to focus in at those that are at highest risk and identifying the outbreaks and responding to the outbreaks. And then in terms of monitoring, we think of it about as we do around flu, where we don't get all the cases reported in, but we're able to use the sources of data that we have, such as outbreaks, such as information from hospital systems about routine testing, because if you're testing all the admits, as well as wastewater surveillance and syndromic surveillance for people presenting with symptoms, you can put together a picture that then allows us to support planning, and there's something we can share with the board regularly, just as we do with flu.
I'm a little concerned that we are underestimating the magnitude of the current
Yes, yes, it's very much higher than the actual case numbers.
I actually heard something on that, and this is just the news, but the news talked about the fact that it's a large number of people who have been safe and protected and never got it for the first 2.5 years, and now are getting it, presumably because the vaccines aren't as effective against the current, popular variant or whatever it is. But so anyway.
Yeah. I think the message remains that that even earlier vaccinations do offer some protection. What we're doing is really reducing the level of hospitalization, seriousness of disease and death, but obviously not providing a high degree of protection against kind of lower level infection, and that's why boosters remain such an important part of our protection.
A little more like traditional disease surveillance versus what we got used to in COVID, where we were trying to get every single case. If we just are looking for the activity, that's the important part.
Yep. And Dr. Rysich, Wilson Community Assessment Manager. One of the advantages for our wastewater surveillance system is that captures asymptomatic as well as symptomatic. So it is an important piece that we're expanding. I think you've heard that we've got one site. We're still trying to get a second site up, and we'll continue to explore that. So about 30% of adults that have COVID are asymptomatic. Roughly about 70% of children are asymptomatic. So it's really going to be an important tool for us capturing and understanding the full burden of disease of COVID-19 in Pierce County.
Board Member Kimmel.
The surveillance, wastewater surveillance, you're using, I believe you said the Portland Avenue.
Puyallup.
Puyallup Avenue.
No, I'm sorry, the city of Puyallup.
Oh, city of Puyallup. Yeah. Okay, so you haven't gotten with the city of Tacoma yet.
This is a Department of Health's program, and so Puyallup identified themselves as one of the sites that they would like to participate. So one of the things that is important about that is that they have to do an in-kind donation of staff time. So we're moving towards getting other sites into the system, but currently we have one, and we're exploring University Place, Chambers Bay as the second site.
About how many in the current one? How large of a population catchment is that?
Don't have that number, but I can. I'll make sure to get that for you.
Thank you.
All right. Well, thank you for the update as always. And I'm assuming we don't have executive session today. Before we adjourn, a couple board member comments. First, since this is the last meeting that we'll have this month ahead of Pride, I just wanted to note that I believe the city, the county, and some of our other cities are beginning to issue their own proclamations, but I think it's important that the board acknowledge that the importance of the relationship that the health department has with the LGBTQ community, and for all of our employees. Want to wish you a happy Pride, and also, coming up this next week is the first Juneteenth celebration, which of course relates to the equity work that the health department has always been active on. And so I believe the health department, the city of Tacoma, Pierce County, as well as probably some others around Pierce County, are all celebrating Juneteenth for the first time as an official holiday within our agencies, and so I wanted to wish everyone a happy Juneteenth and enjoy the celebrations. Any other board member comments before we adjourn? Seeing no further comments from the board and no further business, we are adjourned.